Katy Lees, Principal 340B Compliance Advisor with Virtue 340B. Welcome to this installment of Katy's 340B Compass. Welcome back if you joined us in the past or if this is your first time. I'm so glad you're here. As always, I guess I'll start by saying I would love to hear if anyone has any topics that you'd like me to cover. I mean, the 340B space is definitely not leaving us, lacking of any topics to talk about or deal with or manage. But I just would love to hear, I do love to hear feedback. If you have anything that you want to share, any topics you think we should explore, or just anything you want to say, drop me a line through the Virtue 340B website, on LinkedIn. If you know how to find me otherwise, I'd love to hear from you. So today, there's just, as I said, so much to talk about. I was putting my notes together and I don't even know if I have some clear consolidated thoughts, but I guess do I ever? There's so many things that just keep popping out at us that we need to figure out what to do with, how to manage, what to think about it. So I guess I was going to start with just talking about the HRSA's request for information. I know I covered it a little bit in my last video, but we got an extension. So we have until April 20th to submit our comments. I hope everyone is working on their response. Whatever your position is, what type of stakeholder, your perspectives, HRSA should hear from you. I'm not sure if our comments are going to change the course that HRSA is on at this point. But let them know what your thoughts are about this rebate reboot. What will that mean for you? They've asked some very pointed questions, and I don't think that we can truly give them as meaningful answers as they would like, and maybe we would like to provide, but providing this information that's going to be published and available publicly, there's just limitations that we have to abide by. So, we cannot provide contractual information or certain financial information. That's just not feasible. So I know one approach that I am considering and think I will be including in the response that I'm helping put together is, to say that there's just limitations on what we can provide in answering these questions, and offer, if there is a different mechanism to provide information, to provide feedback, answers to these questions that would be protected, would not be published or publicly available, that could be an option. Is there some sort of survey that HRSA could, send out to the public or send to just certain stakeholders, certain covered entities, or it just, maybe there's some just direct dialogue that needs to take place between HRSA and certain covered entities or stakeholders, just so that they can get more meaningful information if it's truly going to be used to, make sure that all of the appropriate steps are taken. So, there's that. It's definitely, that makes it all very challenging. But, what I wanted to share more about this is our chance to just really go on record and share our experiences. We can share real operational implications and experiences that relate to these questions, or, what the future might look like, what we hope the future could look like, what we really want it not to happen. So maybe because, in light of those other limitations, this is where this can be our strength. This can be, one thing that I have been thinking about and focusing on and trying to really put together in a meaningful way as part of the response is our experience so far with MFP. So this maximum fair price policy that's now been in place for a little over 2 months. How's that going for everyone? Think about those details. That could translate into what a rebate policy would look like. So are you getting the rebates that you're entitled to? What is that dispute process? How is that going for you if you're not getting those rebates? Because I know from my experience, rebates are not being paid. There's, it's hard. Like, I understand there was not an appropriate mechanism made available to determine 340B versus non 340B transactions, but that's not necessarily the fault of covered entities. I don't think it's the fault of pharmaceutical industry either necessarily. But it's a fact. That is what we're living in. Even if we take out, the complexity of, okay, so it's almost impossible to truly determine which ones are 340B versus not, then let's just focus on the dispute process. So you can dispute one prescription at a time, and you just initiate it, and then you're given, there's some back and forth. It's not just you say, this is not a 340B prescription, I need my MFP rebate. Okay. That does happen if you tell them it is a 340B prescription and you want to give them back the MFP rebate. That is simple. But if you are disputing that you were owed a rebate, that's a fairly lengthy process. I was talking to someone about it today, and we're estimating that's a 20 to 30 minute process from start to finish per prescription. I know firsthand that there's entities out there that have hundreds of prescriptions to dispute in just the first couple months. So that is real information that should be shared in the RFI if anyone else is having an experience like that. Another thing that I think is important that I really, really, really want HRSA to be considering, and I don't think this is a surprise to anyone who is logged in to hear Katy's 340B Compass in the past, is why do we have to jump to rebates? Why can we not just have some sort of standardized data sharing process, some neutral clearinghouse where covered entities can submit their data? I don't care. This is probably, I tend to have these unpopular opinions, but I don't even necessarily need it to be limited to the MFP drugs. Like, it could also be used, we could benefit from it in the Medicaid space. We could standardize, preventing Medicaid duplicate discounts and take out a lot of that guesswork. And mind you, from my perspective, the guesswork is more on the just, maybe lack of visibility, misunderstandings, things like that. Not necessarily that there's, this like rampant fraud and abuse within the 340B program and so many Medicaid duplicate discounts occurring. But that's definitely something that I think is important. If anyone else shares, my perspective on that, let's tell HRSA that. Let's tell them the things about that we think would work. The similarities between a rebate program and what that could look like, aside from the disruption and the financial implications of just completely, jumping from these upfront discounts to a retrospective rebate model. Talk about when we were planning for the rebate program and we were trying to make sure that we were going to have all of the data available. What was that experience like? What was going to be the biggest challenge for me? And I know many other conversations I've had, it's medical claims. So, there's, for one, if the expectation is that a medical claim is submitted after it has been billed or even paid by the manufacturer, paid, reimbursed by the payer, then that is a big challenge and just a very flawed process, because I just don't see how that works. Like, I need to be able to pull information in a consistent, standardized manner, and that's not going to be the case if we have to wait for things to be billed. There's not just like a standard timeline. It varies by payer. It varies probably by drug, by setting, by so many different variables. So, if we have to submit medical claims, which again, I'm saying I'm not completely against submitting data, then we need to do that. We need to develop a process that's just feasible and makes sense operationally. So let's do it based on charge data. Charge data in most hospital settings, at least, or outpatient department settings, is once the drug is sometimes dispensed. I think oftentimes when it's administered, a charge is issued. That has most of the relevant information that could be submitted. I would definitely that's something that I think HRSA should be aware of, is details like that. There's a couple fields that were requested, in that data that was going to be collected for the initial rebate pilot, payer ID, And then even like a unique hospital ID, like what do those represent? And are they really going to be standardized and mean anything once submitted? Like, let's make sure that the information being requested actually serves a purpose and makes sense and is feasible. So these are some of the comments that I think will be helpful, even if we can't provide this, real financial, operational, contractual information. Like, let's help them understand what this all looks like or would look like from an operational perspective, and just what the challenges would be. I guess maybe the last thing that I'll say on this part is we can't take the stance that everything just works and no changes are necessary, because I think we're long past that. I think, to be honest, that position has not helped us. This is, I'm not going to say that it is the reason we are where we're at, but it certainly didn't help us, kind of find a better path along the way. So, we have to come to the table with some compromises. We have to come to the table with, some other recommendations, not just, nope, this isn't going to work, everything's fine, because everything is definitely not fine. So that's that. Again, get your comments in by April 20th. It's important, if for nothing else, that we get our voices heard and we get it put on the record. Kind of staying in that line, I'm just thinking about so many things that have been happening, and I feel like there's one theme, and even the RFI, it fits in this theme, it all comes down to transparency. Like, that's what we've been hearing about for years now. That's, one of the top complaints. There's not enough transparency in the program. And, I guess it just all has me thinking about, like, what does transparency in the 340B program mean to, I think it means something different to like every person. So I guess I pose the question to anyone, listening today is, what does transparency in the 340B program mean to you? Because to me, it means, making more data available to maybe solve for compliance issues. So we'll go back to the maximum fair price. We need some transparency. We need data to be made available, whether that be, this is not always a feasible, definitely not a popular thing, but whether we need to apply modifiers to these transactions, like that is transparency. That is labeling and identifying 340B transactions. That would help. That's not my first choice. I'll be honest. What I think is, what I've already mentioned is, having a central place where we can submit the data so that all parties that need that information have access to that information. So that Medicaid has access to what is 340B, so that manufacturers have access to what transactions were 340B. Covered entities have those answers. And I don't think it's completely unreasonable for that to need to be shared at this point. I mean, it's kind of just inevitable that that's the path, obviously. I mean, I'll talk about some other points that's certainly the path we're on. That's the path we've been on for a while. But what needs to happen is we really need to, again, to have some type of oversight, whether it be owned by HRSA, or if that's, if it can't be HRSA, like how can we standardize this process, but have it regulated, or have some sort of government oversight on it, or some sort of neutral body overseeing this information. But that's really, that's what transparency means to me, is sharing of the information so that you can validate compliance, so that we can nip all of these, the narrative that there is so much fraud and waste and abuse in the program. Let's put it out there. Let's all look for duplicate discounts together. If we identify them, and it's complicated. Inevitably, there are. It happens. It does. Let's have a process to take care of those. Let's submit the data. Let's identify if a duplicate discount has occurred. And if it has, then let's have a process to take care of that. We can do it with the maximum fair price transactions. We can do it with Medicaid. If we're sharing all data, it can also go to the third parties, being, the pharmaceutical industry and maybe the payers for commercial claims even. for the purposes of identifying and making sure that people for business reasons have what they need. But there's certainly limitations. I don't want to what I feel like what I just said, I probably shouldn't have said, because we're not sharing that information to impact reimbursement so that, for-profit companies, that the PBMs and insurance companies can reimburse differently or, for things like that. But I do understand if the pharmaceutical industry needs to know which transactions are 340B because they have business agreements that are impacted by that, then I think at this point it would probably just be better just if we all had that information and we are all working off of the same map. So that's what transparency means to me when I think about it. I'm just thinking about all of the current events lately. So, I guess staying in this lane, talking about the new policies that Eli Lilly and Novo Nordisk have put out there that they want covered entities to submit all data. And you might say, hey, Katie, that's what you're talking about. You must be okay with that. Well, I'm not. I don't think that each individual manufacturer should be able to make their own rules, use their own vendor, and they can change this on a whim, just like we have dealt with for the past 5.5 years since, was it July 2020 when Eli Lilly was also the first one to publish a new contract pharmacy policy. We can't live in a world like that. We need some stability. We need some standardization, consistency, oversight. We can't just be following 100, it's not gonna be 100, I know, but let's say 20 or 40 different policies for submitting data, what we submit, who we submit it to, how often, what the parameters are. And then it's just up to each of those individual companies that obviously are just very biased and interested in their own business practices to say whether we're doing it right or not, or more so maybe their vendor too. That's another player. The vendor they've selected. It's up to them to make sure it's all working. And we have zero recourse. We being covered entities, we don't have any, there's not a regulating body that we can bring a dispute to or that can make sure that things are being managed fair and reasonably. So while I'm okay with data sharing, it's not okay to have these individual companies dictating those terms to us. It's really challenging, very challenging. We need some guardrails. We need some standardization. And then I can definitely get behind that. Switching gears a little bit, but still staying on the transparency topic. We had in Minnesota, they have a state law that required data, that's a transparency law that went into place a couple years ago. And last week, the news was, the crazy big dollars that they're spending, that our hospitals are profiting from in the state of Minnesota. And, I'm not going to spend time right now, at least, going into any deep details on that, but I just mention it because obviously that is the type of transparency that the pharmaceutical industry has been pushing for. They are asking for things about the revenue associated with the 340B program for covered entities, the patient type, payer type, where the types of hospitals and their child sites are located. I'm not saying all of that's in the Minnesota law, but that's the type of transparency that the pharmaceutical industry has been asking for a long time. And I'm not here to bash. I'm biased. I don't think anyone is surprised by that. I'm not here to bash, but I'm just saying it is very different what they've been looking for. And I do think that a lot of the intent of that, at least from my perspective, my opinion, is to just create a narrative. Then that information, that's what we saw last week from the release of the reports in Minnesota, is that information is just applied in so many different ways and just, I think, in a lot of times inaccurately. First of all, these hospitals are not profiting. I mean, all of it is reinvested. So it's definitely not the same. you don't know exactly what all of that dollars amounts to. Like those hospitals could still be in the red because everything else they do loses money, and the money that they make from that is used to stretch their scarce federal resources. Like that was the intent, is the intent of the program. So, that's like a piece of the puzzle, and you have no idea what the whole puzzle entails. So that's where I have an issue, and I don't necessarily get behind that type of transparency. What purpose is it serving? Like, except that it's being used for headlines and to, try to sway people in one direction, and against safety net providers. I mean, it is crazy, like how effective some of those strategies are to paint these health systems and health centers that are supporting sometimes the poorest of the poor, the very unhealthy members of our communities, and I mean, just supporting our communities as a whole. And here they're often made out to be the monsters. So I don't know, I guess I'm getting a little bit too opinionated in my spiel today, so I apologize. But, so that's why safety net providers, covered entities, are very, apprehensive about that type of transparency, because it's just, if that kind of information was shared, it would really need to be done, so that all of the right context, all of the right details is known, so that it's actually useful, accurate information. And then, so the last point that I was going to talk about, again, still on transparency, but taking another turn again, is the court case this week, the ruling that HRSA doesn't have the right to require hospitals to register offsite departments as a child site before they can be 340B eligible. So I'll be honest, that case was not, it kind of had fallen off my radar. I mean, there's so much else going on that I wasn't expecting that when I saw that. Was it yesterday even, I think? It's good news. I mean, it's being celebrated, and I get that. I totally get that it's being celebrated. But I do feel like it's good news on the surface, because I feel like every time HRSA loses one of these battles, it's another dent in the 340B program. Like, it's kind of a loss for all of us. I'm sorry if that's, an unpopular thought, but, we need HRSA. Like, we need infrastructure. We need the 340B program. We definitely need the 340B program. So we need it to have a regulating body. We need some rules. Like we have to have rules to function. We have to have rules so that everyone, all the other stakeholders in the 340B space know what we're doing and that what we're doing is appropriate. So, I don't know if the rule has to be that there's a waiting period for the cost report and the registration of child sites. Like, I'm not saying that, but we do need something, because it's not working the way it is. We can't have HRSA, lose every time they try to either make a rule or enforce a rule. So I don't know, that one's just not sitting great with me today. And again, that comes down to transparency, because other stakeholders have a right to know how, not how hospitals are using 340B, but if you have a hospital that maybe covers 3 counties and you're using 340B in all of these different sites, like, it makes sense that that information should be available, and that there should be some sort of a process to make sure there's controls there. And again, I'm not saying that what HRSA is trying to enforce absolutely should be the rules. But, there's room for improvement. There's room for transparency. OPACE has a lot of information, but I know that there's things about it, like the shipping addresses, for example, that they're not always super transparent. I know that the pharmaceutical industry, they wonder what these shipping addresses represent. And that was one of the things that HRSA recently published in, they wanted to define some of these rules you would have to, I think, if it's a pharmacy, I believe like it would have reflected that more than just the address like it does today. There would have been some more guardrails or just, I don't even think they were changing the rules, but just maybe more defining and making sure that their expectations were more clearly, available and they were guidance, more clear guidance for covered entities to follow, for the timing, how you have to report the financials, things like that. Like, again, I don't necessarily think they were trying to change the rules. I think they were just trying to better define them and just put some structure around all of it, which again, I think we could use that. I think, that also is the kind of transparency that we could use. I don't know exactly I clearly don't have all the answers, but I care about this program and the covered entities that participate in it, the communities that need it. So I hope we can find a way to figure it out. And I do think that a big key to that is through transparency but doing it right, doing it well, really putting some, we need to find a way to collaborate and figure out the best way together, but I'm not sure if that can happen at this point. But yeah, it's definitely never a dull moment in the 340B space. So yeah, I am, if anyone, wants to reach out, or I'd love to hear what transparency means to you. Whatever type of stakeholder you are. Like I was kind of, I don't know, went a little off the rails in my discussion today and some of the points, but I truly try to see perspectives from, other stakeholders within this space. I think that's important in every part of our life. So, I have very fine communications in some even relationships with people in the pharmaceutical industry or companies. We need to work together. I've been in this space a long time. I know we need to work together. So it would be awesome if we could find a way. But yeah, I got a little off track again. Whatever role you play in the 340B space, if you feel like reaching out or, leaving a comment somewhere to say what transparency means to you in the 340B space, I would be very interested. It's ever since I really started to ponder on that, I don't know, again, just all very interesting, never dull. I hope everyone enjoyed today's episode. I always feel like I end these and I'm like, wow, was this helpful? I hope it was helpful. I hope everyone's working on their response to HRSA on the request for information about the potential reboot of the rebates. And just, it's important to stay on top of all these topics. They have real implications, and, whatever we can do to, it's hard to think that we're going to make a difference or influence, but we can. We all need to, at least locally, we all need to, do what we can to make a difference and to make the 340B program as just sustainable as we can. So, we need to get out there, do our advocacy, again, respond to the request for information. Don't jump all in on this response from the case this week with HRSA. I mean, again, we need to celebrate it, but also let's think about that a little bit more meaningfully and just what all those implications are. And yeah, I guess I'll just stop it there. I hope everybody has a great day, and we'll talk soon. Bye. Do you have a 340B compliance question? Send us a message at virtue340b.com. Thanks for tuning in, and we will see you on the next episode for more expert 340B advice. Talk to you soon.